This conference will now be recorded.
Okay, gents, welcome everybody to the high-risk recurrent advanced prostate cancer video chat virtual support group. And it is the 1st of September. Happy 1st of September, happy Prostate Cancer Awareness Month, and happy Ovarian Cancer Awareness Month, and happy any other month that, that you care. And for our Jewish friends, happy Elul and a happy New Year. We can start saying that now. We have already 15 people, and there are at least 2 or 3 more who are currently listening to Richard Wassersug give his androgen deprivation therapy presentation to the Tucson Prostate Cancer Support Group. There were 53 people on that call when I left it about 3 minutes to the hour. And I do know a couple of those people have issues that they would like to raise today. So I will reserve time for them. They won't come on probably. I would expect them to arrive after about 40 minutes into the call. The good news is we don't have anybody new. So we should have time to get around everybody. I guess I always say that, and then the next thing somebody new shows up well into the meeting. Looks like we lost Larry Aldona. No, he's there. Okay. All right, let me run down my list and see who's here. Somebody just came in, AnCan Barniska's room. It's not Peter. It's not Ken Anderson.
It's Peter Monaco, maybe. I'm not on camera yet.
Monaco. Okay. We are very happy to hear from you, Peter. We could get we will ask you for a non-prostate cancer update as well.
Fine with me.
Okay, and we have one person on the telephone. Who might that be?
Hey, Rick, this is Madhav Mohan.
Hi, how are you?
I'm doing well, How are you, Rick?
Good. Okay, let me just run down the list first of all and see who would like, well, let me first of all run down the list. We've got myself, Jake, Peter, Kafka, Ken, Paul, Dennis, Dennis C, Joel, Russ, Len, Larry, Lou, all the L's, Jerry, Peter, and Mr. Mohan. Did I miss anybody?
Miss me.
And I had you written down. Okay, it was those 3 L's that got me. Okay, let me run down and just see who would like some time today. Bear with me 1 second. Okay, so, and I've got 2 guys that I know, Carl Foreman and Rich Jackson, both will want time. Jake, how about you today?
Nothing for me, thank you.
Okay, Peter Kafka, anything for you?
Yeah, I've got a couple of things that might be of interest to people.
Okay, Ken Anderson.
I can give an update since I got new labs.
Okay, are you in the Northwest?
Yeah, I am.
Okay, Paul Freda.
I have the door open. That wouldn't be in Phoenix.
Hey, it was 72, 73 degrees all day here yesterday.
I'll be dang, that's pretty cool.
I know. Paul Freda.
Nothing for me tonight, thanks.
Okay. Dennis McGuire, I know you need time. I got you ticked already. Dennis Correa, anything for you?
Yes, Rick, I'm going to give you an update on my annual scans.
Good, good, good. Joe Blanchette, anything for you?
No, not unless the guy who's coming in the room late, who has my same situation, unless we want to talk about it.
Yeah, we will. So when Rich comes in, we'll get a little conversation going between the two of you. Len, anything for you?
No, thank you.
Okay, Russ, anything for you?
2 minutes.
2 minutes? Okay.
2-0, just 2 minutes.
Okay.
Need a timekeeper to verify fact check.
I'm sorry, what was that, Mr. Fish? I was just about
We've got to fact check this 1 minute, 2 minute business.
Oh, okay. Thank you. Okay, you're in charge of fact checking. And would you like any time for yourself, sir?
And no, thank you, Rick. No, thank you, Rick. No, thank you, Rick.
Okay. Lou, anything for you today?
No, I'm good, thanks.
Okay. Herb, anything for you that you'd like to raise?
Yeah, I would like some feedback from the group.
Okay. Jerry Pelfrey, down in Mexico, San Carlos, anything for you?
He's muted.
There we are. I had some new labs done here by a good lab here, so I'd like to update those.
Great. Tina Monaco can give us a quick update. Madav, anything for you?
Yes, Rick. I have an update on my new diagnostics, the clinical trial, and my treatment.
Great. And Jeremy, anything for you?
I'll just update the group with some new test results.
Okay, great. All right, guys. So we got a bunch of people. I will say that we will have to clear out this room pretty promptly today because I've got a 5 o'clock advanced caregivers, cancer caregivers meeting starting. I'm sorry about that. Usually it doesn't happen, but because we had to shift the meeting back a week, I don't think anybody wanted to have meetings on successive nights. So we accommodated the weird September schedule by moving the Tuesday meeting back a week. But it does mean that this meeting and the next Tuesday meeting, we will have the caregivers following us in at 5 o'clock. So we can go right up to the hour. We can literally go right up to the time that that the caregivers start arriving. So, and if it's only, and to be honest, if it's Susan LaHaye and we have a slow caregivers night, she won't mind if we keep talking about prostate cancer. So we may be able to extend a little bit. All right, so let us start with Peter.
Okay, just a couple of update things. One, I was just on the phone with Alex from Prostate Cancer Research Institute, and she had asked me, I just want to do a quick announcement that their annual meeting, which is usually held in LA at the Marriott, and we participated in, is going to be online this year, and it's the weekend after this, Friday the 11th and Saturday the 12th, from 8:30 to 2:30 Pacific time. And you can go to the PCRI website and register, send in questions, and they've got a good lineup of a number of speakers, including Dr. Klotz and an expert in pathology. And anyway, a number of people. You can look at the agenda and so forth. And they're certainly worth supporting. They expect over 1,000 joining them this year, and it's free this year. You can just register online. So that's one thing. Rick, I'll talk to you later about our conversation, what came out of that. Just a couple of odd things. I think I mentioned on several meetings that one of the side effects I had from my chemo was some edema, swelling, pretty good swelling in my legs, particularly below the knee, thighs, feet, very much so. And it had gone on for a month or so. I tried water pills to no effect. I tried it for 5 days. Anyway, that was a month ago or so. And then Sunday night, lo and behold, magically, as I've heard other people say about disease, it can just disappear like magic. And it did. The edema overnight, I lost 6 pounds, all to fluid retention. Woke up in the morning with no swelling. After 2 months of edema, and it's gone. So that's one happy report. Another thing that happened Sunday was I'd spent Saturday night down at my partner's house. I spent a number of nights down there last week with her, and I woke up Sunday morning. I was just feeling really pumped. You probably know the feeling well. I just couldn't pick myself out of it. I was dragging my butt around all day from that, and I couldn't put my finger on exactly what was going on. I just felt terrible. Anyway, I got home and doing this and that, answering emails, and I took my temperature, and it was up at 99.6. And I thought, that's odd. It never goes above 98. And I took it about an hour later, and it was 100.1 or 2. And I started thinking, what's going on here? So I went to bed early. I asked my son to check on COVID tests, where I could get it. This is Hawaii. It's kind of the last place in line to get them, particularly Maui. So Monday morning, I started checking it out. I felt better Monday morning. As I said, I woke up, my swelling was down. I didn't have a temperature anymore. But I said, what the hell? I owe this to my partner. I might as well, see if I can get a COVID test. So I got online and filled out the form and this and that. And they told me I qualified, and went down. It was a 15-minute rapid test, and zipped down. It took me in about right away in a few minutes in the parking lot. Waited 15 minutes, got the negative results, and went home. I don't know if any of you have done this before, but it was pretty slick. So it was the habit 15-minute test, which is a what do you call it? The antigen test. Anyway, so that's good news too, that I don't have COVID, because my situation's still like I've got to go to the hospital Thursday and do get a Lupron and Prolia shot. I've got to go. I went last Thursday to get a ProQuit shot. I've got to go next Thursday to get another ProQuit shot. So I've got to utilize our hospital quite a bit, which has had an outbreak. It's got some 69 staff and patients, 21 patients in the hospital with COVID, and a bunch of staff on.
So Peter, this is all very good news, especially the edema. I mean, I will tell you that I personally have been going through something similar for about the last 2.5, 3 weeks. Today is the first day that I really feel significantly better. Temperature's been going up, been going down, and I don't know what's been going on. I happen to think it's some sort of a kidney stone, gravel, but I had something wrong with my gut too. But I think it's got something to do with a UTI. So I was just going to ask you if you've had any sort of urinary issues at all? And, you know, gravel, blood in your urine, anything weird like that?
No, but at the same time, the same nurse who did my COVID test, I gave her a urine sample too. She handed me a jar, which I did, and then while I was waiting for the results, they tested my urine as well. So I got 2 for the price of 1, which is pretty good. Came back.
Anybody got any questions for Peter or comments on some of this good stuff that's going on?
Yeah, I do. Peter, what was this, a throat swab or a nasal swab? The 15
nasal swab.
Nasal. And the 6 pounds of water that she lost, was that seriously overnight?
Yeah, I weighed 100. I weighed 190 that night, and I weighed 184 in the morning. I mean, I woke up several times, numerous times peeing. I peed an awful lot during the night, but I wasn't on a diuretic. I wasn't on a water pill. I just kept getting up every 45 minutes and peeing.
I wonder if the slight fever you had may have been a little bit of dehydration after losing 6 pounds of water. Possible.
No, I had the fever before I went to bed.
Oh, okay.
Guys, I'm going to move along because we've got about 10 people that want to speak today.
Okay.
Possibly more. So we've got to, I do want to try and keep moving, and we've got a couple of issues that might take a little bit more time. Ken Anderson, you have some updates?
Yeah, just some updates, something real quick. You know, I did listen to the recording with Jake when he talked about his PSA didn't go down quite as much as he has hoped after, you know, another round of chemo, and mine was very similar. You know, the first round of chemo, it dropped about 20. The second round of chemo, it dropped 0.2. So it dropped from I'll tell you, it dropped from 34.8 to 34.6. And it was at a high of 41.3. So I don't know. I think cell cycle date maybe. I mean, I like Lynn's comment, but I don't know. It's pretty hard to predict, you know. I did notice after this last round of chemo here in the Northwest, though, that I was starting to lose hair again. So, which hadn't happened the last 3 rounds. So I don't know if it has to do with how cells multiply, or I'll be curious to see. It went down, not going mental because it went down. So that's about it, though. Working my butt off on this old house, though, which is good for me. Moving boulders and using a tractor, and replaced the door, front door today. So.
What do you do? Hire a tractor there?
Say it again?
Did you hire a tractor?
No, my stepfather has a little Kubota that I drug down here, and I have like a big pile of boulders in the backyard I've been moving.
Okay.
So, I mean, I'm getting around, which is crazy. I thought, you know, 5 rounds of chemo, I should be on my butt, but I'm not on my butt. So I did notice it, though, the 4th day. I was on the sofa that whole day. So I definitely felt chemo. It's just I'm not going to let it keep me on the couch.
Good for you. Ken, Len, any thoughts, or Herb, any thoughts on this cell cycle that we talked a little bit about last week, and Ken's response?
Did you talk to Paul Korn, Ken?
You know, right after I got the results, I sent him a note I sent him my labs, and I must say my white blood count's fine. There's really nothing out of normal. My alk phosphatates did go up, though. My T levels went up just like 1 point from like 1 to 2, but the alk phosphatates went up about 15 points. So there's some bone activity, I know that. I don't know. Paul hasn't replied, though. You know, if it was of any concern or something I should make a change, he would have sent something fairly quickly. And since he hasn't, he'll get to it, but he'll get to more important things first.
Okay. Anyone else have any thoughts or comments for Ken? I mean, you know, I don't think there's anything wrong with you plateauing there for a while. I mean, the fact that the alk phos is going up does certainly indicate bone activity, and the likelihood is, since it's right in the middle of chemo, that it's positive bone activity and not negative bone activity. But that's my own gut interpretation. Herb, well, what would you say about alk phos going up in the middle of chemo?
I mean, I think it depends on how much and how fast, and if it's, you know, if it's a trend or just a single observation.
Well, it had been going down, you know, it's like, I guess at the high, make sure I'm saying this right. Yeah, at the high it was 65. And it went down to 52, then 50, and now it's back up to 61. So I don't know. I have it graphed, so you can see on the graph pretty easily that it's.
That's still pretty low.
Yeah, and these are not
Those
big
are
numbers.
those are not actually outrageous numbers.
They're not.
No.
Well, I'm always very low. Even in the very beginning, I was in like the. I've always been super, super low on alk phosphatase. It's not really a good measure, but I have been watching it. But even Paul said, because at one time it was 36, you know, which is pretty low. So I don't know. For me, maybe it's not a good thing to watch in as far as activity, but I still graphed it just like my T levels.
What is that a measure of?
Bone
remodeling.
Yeah, repair, really. Bone repair or damage from cancer. You know, if you have a lot of prostate cancer attacking your bone, your alk phosphatates will go up. So
I mean, my understanding, and you know, I stand to be corrected by anyone here, but especially Len and Herb, is that it's really a measure of bone activity. So any type of real action in the bones, whether it's the bones building or the bones falling apart, releases alkaline phosphatase into the bloodstream, and so you measure it. So you don't always know if it's for a good reason or for a bad reason. So if you are building METs very, very quickly, you're going to see higher alkaline phosphatase. At the same time, if the METs are being destroyed and by the chemo, you're going to see a high alkaline phosphatase. So it's just like, you know, it's a bit like PSA. If the number's elevated, don't jump to conclusions. There could be a bunch of reasons.
well, I'm going to jump on the latter of the two.
Okay. All right. Well, I'm going to keep moving, guys, just because of the number of people that want some time. And let me just check. I've got two new guys. I know that Carl would like time today. Let me check with Les. Les, would you like any time today? You're muted right now, Les. So Les may have stepped away.
Yeah,
Oh, there you go.
No, I don't need anything. Thanks.
Oh, good, thank you. And Jim B, these are all refugees from Dr. Wassersug. Jim, you're muted right now, by the way. Would you like any time today? Yes?
Sure, I have a minute.
Okay. All right, we are going to try and get through everybody, but we may miss out on a couple, I'm afraid, but we will do our best. So next I'm going to stop by Dennis McGuire, who I know saw his RADONC this morning, and we had a chat last night, and also Dennis spoke with Len. So Dennis, why don't you update the guys on your recent PSA, any other tests, and your conversation today with Dr. Lang.
Sure. So here's the background. I finished radiation to the prostate and a lymph node and a spot on my left hip in April. Got a quick response to the radiation, and my PSA went from 14 down to 6 over the course of 2 months. And then 3 months later, just last week, a new PSA reading came in around 10. So had scans on Friday and reviewed those today with Dr. Lang, and it appears that there's 4 lymph nodes in the pelvic area that are still active, that were not radiated. And he believes those are the spots that are generating the PSA. So, you know, good news is it looks like the radiation worked on the targeted areas for now, but those areas that were not radiated puts me at a decision point on what to do next. Several options out there. Having just been introduced to those options, I'm a bit overwhelmed right now, so I'm just still taking all the information in and trying to figure it out.
Well, as you well know, Dennis, last night we did talk a little bit about why they decided originally not to radiate your pelvic girdle when they radiated the prostate. What were the options that Dr. Lang put on the table, and was one of them pelvic girdle radiation?
Yeah, I think on additional radiation to the pelvic area is a possibility. I need to have a consultation with my radiologist on that, which should be within the next week. He's really going to help me make that decision. So that's option one. Option two is a clinical trial that Wisconsin is a leader on, which I sent to you guys, Rick and Len.
Yeah.
Kind of unusual trial. I don't think you guys have heard of it before.
Is it an immunotherapy trial, or what kind of trial is it?
It's a glucocorticoid receptor. So it works similar to the androgen receptor drugs, where it blocks the glucocorticoid receptor.
So is it with one drug, or is there synergy with more than one?
Well, it would be, you do it along with Xtandi, which I'm currently on. But it's early. It's probably late phase 1, early phase 2, which gives me some cause, to be a little concerned about that. So I don't know if that's a good option.
So let me just say before you go into the other options, I've just put the reference to the trial in the chat window. And why don't you run through the options, and then I certainly would like to ask Glenn and Herb their opinion on this trial, and what were the other options that he laid out for you?
Well, certainly chemo is always an option. I did respond well to docetaxel 5 years ago, my first treatment. upon diagnosis. But Dr. Lang does not recommend that at this point. He thinks that might be a little too much right now, his opinion. And then there was another trial that Wisconsin's involved in, which is an immunotherapy. It's Keytruda combined with a vaccine.
Well,
there's three research centers involved in that. Wisconsin, Johns Hopkins, and UCSF. That's a phase 2.
Okay. So let me address the low-hanging fruit. I personally, because it worked for me, and because it is probably the greatest proponent of this was the radiation oncologist who treated me, is that men who have more advanced disease should get pelvic girdle radiation. And it did puzzle me a little bit that they didn't do that when they radiated your gland, especially given the stage and where they thought the prostate cancer was. And the fact that you tolerated your radiation real well, number one. Number two, the fact that there is the technology at Carbone to deliver pelvic girdle radiation through SBRT. I think both of those would suggest that might be the first step, and see where you go with that. And then, by that time, possibly these trials are further along, because to be honest, phase 1 and phase 2 trials are, excuse the pun, a pain in the butt. Because you've got to be in and out the hospital every week, and they're busy taking all kinds of blood tests and So that to me is the low-hanging fruit. Let's also deal with the chemo. If Lang feels that that's over the top, I'm sure he also feels that the Pembro with a vaccine is over the top, because I can't imagine that they would want to give you pembrolizumab and a vaccine if they thought that chemo was more. But I guess I'm putting words into his mouth. What I don't know is, or don't even understand, is this glucocorticoid. I don't even understand the theory of it. And I'm hoping that Len or Herb can maybe explain a little bit why a glucocorticoid in conjunction with enzalutamide might have a positive benefit.
Well, I hope you have something, Herb, because I don't. I've never heard of this selective glucocorticoid receptor antagonist, or how it would help.
And I'm with you. I just looked at the trial, and it's really a phase 1 dose escalation toxicity trial. It's not designed to cure anybody. They just want to know if it won't hurt you. So I'm not sure that's what I would think would be inappropriate, especially I don't know the rationale. I mean, I'd have to do a lot more reading, because we're all taking glucocorticoids, right? So why would we want to block a glucocorticoid receptor? I don't know. But I think somehow before I went to trials, I would say, let's look at more conventional approaches to some ways you could do this.
So glucocorticoid, is that the same thing as like prednisone or dexamethasone?
Prednisone and yes, dexamethasone, prednisone are all glucocorticoids. So you're all, if you're on Abby like I am, I'm on prednisone because it also blocks the synthesis of glucocorticoids. But I don't think that enzalutamide does.
No, you don't need it with enzalutamide. I mean, you don't have to take it with enzalutamide. So somehow or other, what I said is a steroid in conjunction with enzalutamide is going to have a positive, is hypothesized to have a positive effect.
Right. So I can't say without a little more reading, which I will happily do if Dennis would like us to. I can't say much.
Okay.
So, can I just ask Dennis a question, Rick? I wanted to know, so they saw no bone mets and 3 new lymph nodes, and these were pelvic lymph nodes, is that right?
Can you hear me, Len?
Yes.
Okay, my camera froze up, so everyone's frozen, but glad my mic still works. Yeah, so no measurable bone activity, so that's good. The 4 lymph nodes apparently were there, but they were smaller. So they were anywhere from half a centimeter to a centimeter. And now they're close to a centimeter. And they're all in the pelvic area, different locations. He said one he's concerned about mostly because it's in what he calls the deep abdomen. If I got this right, near the peritoneum. Peritoneum, yeah. So that one is probably the most troubling.
Dennis, have you ever had a PSMA scan?
No, I have not.
Because I'm
I've
just
had an
wondering.
accident.
Yeah, but I mean, I'm just wondering because these things are popping up and they weren't so significant before, whether there's other stuff around that's not picked up by your method of scanning.
Oh, I did ask Dr. Lang that. I said, should we do a PSMA to get a more precise image? Not necessary right now because he knows enough from the CAT scan, the CT scan, that he believes that's where the trouble spots are.
So let me just ask you, Dennis, did Dr. Lang have a recommendation, or did he just present the alternatives and leave it up to you?
Yeah, I think it's still open until after we consult with the radiologist, Dr. Floberg, and get a definitive answer from him if we can go back and radiate the pelvic girdle.
Okay.
Dennis, do you recall the name of the vaccine?
No.
No?
No, I didn't write it down, but it's on their website.
It's probably Prosvac.
No, it's not. It's not. They actually, it's interesting. They have a oncologist at Wisconsin who has created a company. It's called Madison Vaccines, and they do a lot of work with vaccines for various drugs, including prostate. And they have 2 or 3 trials around, I think they're DNA or RNA based vaccines, but if you go to University of Wisconsin Carbone Cancer Center. You can see him on the clinical trial.
Well, again, we do need to keep rolling here, but to me, I think the key thing here is to get with Dr. Floberg and to see if there's any reason why they could not radiate the prostate girdle. And again, Floberg wasn't the guy, I forget the name of the guy who's doing the SBRT to the pelvic girdle. But it is somebody at Wisconsin, because I do remember Alan Edel mentioning that. So when you talk to Floberg, be sure to ask him about fractions of SBRT to the pelvic girdle, because that might allow you to do 5 or 6 sessions instead of 20 sessions. And it also might be more accurately focused. So it's definitely worth raising with him. If the pelvic girdle has not been radiated, which in your case it probably was not, then then it's a target. If the pelvic girdle has been radiated in part, then you would be a candidate for spot radiation. So either way, and we're going to come back to spot radiation, Dennis, a little later in this conversation with Joel Blanchette and Rich Jackson. So listen up, and we'll talk a little more about spot radiation as we proceed. Do you have any questions for us before we move on?
No, that's very helpful. I think I'm leaning that way also, Rick, is to go radiation because of my experience with the first one.
All right. Well, in fact, I think let's do this. Let's go to this conversation right now, because it's pertinent to you. It's certainly on an option on the table for Rich Jackson. Joel Blanchette's with us, who's done it. So, Rich, first of all, thank you so much for stepping in and helping out with Dr. Wassersuger. It was really appreciated. Thank you, thank you. Why don't you update the guys on the results that you just received, and then maybe have some conversations with Joel and maybe include Dennis, and we can talk about these options around spot radiation. The reason why I'm very eager for Dennis and Joel to talk, Rich and Joel to talk, is because Joel is seeing one of our favorite guys, Emmanuel Antanarakis at Johns Hopkins. And Dr. Antanarakis, who is a great GU med-onc, is doing everything he possibly can to keep Joel off of ADT. And I know that is Mr. Jackson's preference. So why don't you update the guys on the results of finally getting your PSMA scan?
About 35 days ago, I had a bone scan, a CT scan. Both came back negative. Beginning of March, I also had a bone scan, CT scan. Both came back negative. At that time, my PSA was about 2.4, 2.49, currently 4. Just had a PSMA scan clinical trial last week. It came back with lymph nodes on the left common iliac, external iliac chains, bilateral retroperitoneum, more numerous on the left side. So basically, Dennis, about the same thing that you're looking at in that area. A couple other spots, one in the neck, an uncertain spot on the 5th rib, right side. Talked to the medical oncologist that's running the clinical trial today, What he had was left side of the groin. There's small spots that for the uptake for the radionuclide that were 0.4 centimeters and 0.5 centimeters. Standard scanning will not pick up anything less than 1 centimeter. So that's why the others came out clear. What he's recommending is right now is a biopsy to eliminate a false positive, because even with PSMA scans, you've got about an 8% false positive chance. If it comes back positive, what he is leaning towards is spot radiation. And then if that doesn't work, then we'll look at some of the other drug treatments, ADT, or something along those lines down the road. So that's, at the moment, that's up until now, I haven't had anything to say. So that's, I've been quiet. And it's no longer quiet on the Eastern Front. I got all kinds of artillery in the background.
You took the words out of my mouth, Mr. J. What is your feeling on doing a biopsy? I mean, it's interesting because these 5 millimeter spots, I think there are a lot of docs that would say they're too small to biopsy. Or is he looking to biopsy some of the other spots?
No, those were the lymph nodes, left side of the groin area were those were the high spots, the large spots, and they were 0.4, 0.5 centimeters.
Okay, so 5 millimeters. So, and are you inclined to do that or not?
The PSA is going up, so there's something happening. I went from beginning of March, or not beginning of March, middle of May until last week, it went from 2.49 to 4.
Okay.
So but all the scans this year have come back, no sign of disease. I don't know if the biopsy would be worth it. I'll talk to the interventional radiologist first and see what their thoughts are. I've got a scheduled appointment with my urologist tomorrow, and I had him send the results over to my radiation oncologist. So we'll kind of get a local opinion of what the options are, what direction is recommended. And then I'll have some bourbon, flip a coin, and make a decision.
So when you're drinking that bourbon and flipping the coin, I'd like you to consider Mr. Blanchette's situation. Joel, do you want to compare notes? Because this does sound a little bit similar to you, doesn't it?
Yeah, about 2 years ago, 2.5 years ago, my PSA crossed over the 0.2 threshold. And when one of my urologists saw that, they said, oh, well, Medicare pays for a bone scan and a CT scan at that point, so we're going to give it to you. So they did. They both came back negative. However, when my PSA crossed over 0.5, I qualified for the PSMA PET scan at NIH. The doctor at NIH says, you had cancer 2 years ago, but your radiologist missed it, because now your cancer is bigger on the same spot, and we can see it. And then when we compare it to 2.5 years ago, we can see that it was there already, but nobody knew it. So to prove their point, my cancer was all in the left iliac bone through 5 scans, MRI, bone scan, sodium fluoride, FDG, and PSMA PET and CT. So all pointed to the same, only one place for cancer, all on the left iliac bone. So they took 3 bone samples out of me under local anesthesia, and all turned out to be prostate cancer. So on 3, 5, and 7 February of this year, I saw a radiation oncologist, which I already knew because he spoke to us at our us two prostate cancer group, and so went to see him, and he radiated, and my PSA has been going down since. I don't know how far it's going to go, but right now it's sitting at 0.8. So from a treatment standpoint, compared to a prostatectomy, a 3 sessions of SBRT is extremely easy. You just show up, and 10 minutes later you're gone, and it doesn't really hurt. And I had a little bone pain that lasted until about 1 April, but that was it. And that was intermittent and only maybe at a one score of 1. So it was a very easy treatment. I would recommend it to anybody. Of course, everybody is different, but yeah, I would recommend spot radiation to the bone. And right now, my radiation oncologist wants to see me only after my PSA ticks up twice from whatever low point it gets to. And then he wants me to take another PSMA PET scan, and we'll see if there's where the cancer is at that point.
And Dr. Antanarakis' view on all of this?
Yeah, he's the one that he agreed. I told him what my radiation oncologist had said about a week ago, and he agreed with that, you know, I should get another PSMA PET scan, and I should stay away from ADT. And also, I've been reading lately, hearing a couple doctors talk on Euro Today, that ADT is not very good for people with a 0.7 and below. It doesn't show any elongation of life, or not very valuable. It's more valuable for people with very advanced cancer, and it kills a lot of cancer that way. But this is something new that I've been hearing about from a couple different doctors. So I'm right at 0.8, 0.7, probably will be at 0.7 next month. So I don't know if that's the reason why. I need to ask him that. Is that why he doesn't want to go the ADT route? I know that Alicia Morgans doesn't like ADT also, but she's trying to move her people off of ADT. But of course, she has a lot of patients on ADT over the years. So a lot of doctors are trying to figure out a way around ADT.
So who has any questions or comments for any on this topic of recurrence and spot radiation and treatments, either for Rich, for Joel, for Dennis? Anybody like to follow up?
Yeah, Peter, I was intrigued by Dennis's comment that his doctor didn't really agree with PSMA scans. I'm in Herb's camp. I think PSMA scans really have a value. And just listening to the difference between Rich's experience and Joel's experience, I mean, I don't know. I've had 2 of them already, and I'm a firm believer that they pick up significant low-grade indication of disease, of metastatic spread, and it's treatable at that low level. And to ignore that or think it's a false positive or no need to do it seems crazy if it's possible to get the scan. So at least it gives you a target to do spot radiation. Otherwise, you're just shooting blind. It's like doing a blind biopsy. So that's my 2 cents.
Someone else? Was it?
There was mention of the PSMA trial. Where were you getting that?
I had one at UCSF 2.5 years ago, and I had one at Stanford last December.
The PSMA clinical trial that I was in is for reoccurrence. They're comparing standard CT bone scans and then the PSMA results to help diagnose a reoccurrence. Doesn't apply to us, but there's another arm of the trial they're using for initial diagnosis as well.
But there have been some studies, phase 3, randomized, which clearly, and this is something that Len pointed out to me, that do actually show a very significant benefit of doing the scan initially. And and it does change treatment, because if you know you have metastatic disease versus you don't, makes a big difference to the way you approach the issue.
NIH did an interim report on the clinical trial that I was in, and they were, that was about maybe 10 months ago now, and they were saying that about 53%, I believe, of their men who took the PSMA PET scan changed their treatment plan.
Right.
But, I would caution you against necessarily following Joel's example, because he only had one lesion. From what you said, Rich, it sounded like you have about 5. Did I get that wrong? Or, you know, if you count the lymph nodes and the rib and the inguinal nodes?
There are a couple of those that they're uncertain, they're indeterminate.
Yeah.
The rib is, if you look at it this way, it's positive, and you look at it this way, it's not. The lymph nodes down in the groin area those were positive, and there are more than one in that area. The initial conversation I had with Dr. Fleming, that's running the trial, was he drew the line at 5. You know, more than 5, you know, radiation's ineffective. The assumption is it's too spread too far. When we discussed it today, that was the first thing he mentioned was spot radiation. So the count that he's got is somewhere less than 5, or the way he's counting it is less than 5. Because he was emphatic prior to the scan, more than 5, you know, spot radiation is a waste of time, is the general consensus.
Right.
The clinical trial I was in is in Norfolk, Virginia. It's Blue Earth Diagnostic, a company out of the UK, is running the trial.
One topic to throw out there, the difference between the Axeman PET scan and the PSMA PET scan. Is the PSMA PET scan far superior to Axeman?
Yes. Yes.
Yeah.
Yes, by the way, I went to that Carbone center at their website, as you suggested, and I noticed that they do have a clinical trial for the PSMA PET scan, the PYL PET scan, right there at Carbone. I'm surprised your doc didn't mention that.
Yeah. That is weird.
Rich, can I ask a question?
Hold on a second. Just hold on just 1 second. Let me just stick with Len. Len, is that trial open right now? Is it recruiting, open and recruiting?
Yeah, I didn't see that it was open or that it was closed. I just searched under clinical trials. I assume that, you know, clinical trials for prostate cancer at Carbone, that one came up. Why would they, I'm not sure why they would reveal a trial that you can't even get into. But anyway, it's something Dennis should talk to his doctor.
what I would do is look it up on clinicaltrials.gov, Dennis, because that's going to tell you if it's recruiting or not. Because there are a number of trials often on clinicaltrials.gov that are listed but not recruiting or closed, and they still list them. So you know, it'd be worth. Herb, your question. You muted, sir.
My question to Rich was, what's the downside of doing the biopsy?
Can't hear you, Rich.
At the moment, I've had like 7.5 hours to consider it. But kind of based on what Rick had mentioned, was that the size of the lesions they've got to work with might be less than optimal for pulling a sample.
Yeah,
Right.
my experience at Sloan Kettering was for lymph node biopsies, they wanted it to be at least 1 centimeter.
Yeah, that's
or it was just too tough to get a good sample.
Yeah, I've heard that before. Look, guys, I'd love to keep this going, but I'm just looking at my list here, and we've got a bunch of guys to get through, and we've got to finish timely. So, of course, next week we can continue this. We can pick it up again. But I think that both Rich and Dennis have a bunch to work with now. They've got some things to consider. You'll do your own research. Dennis, there is definitely the option of getting a PSMA scan at UCSF for $2,750. We know that for sure. It's a trial, but they charge for it, and so you can get it that way. And there may be other options, but it's certainly something. One thing I did want to mention to you in this regard, I don't have time to get into it, but maybe next week. But I posted on our blog. If you're not signed up for the blog, please sign up for the blog. The new rules for somatic testing, next generation sequencing somatic testing, and there are some new rules that will be music to the ears of most of you on this call. And you can read about them, but the very quick summary is that liquid tests are considered separate and apart and a different test from solid tumor tests. So you're entitled to both a liquid test and a solid tumor test, but better still, we finally got FMI's reflected opinion on whether you can get more than one test in a lifetime. And the answer to that is, if there is disease progression, FMI thinks Medicare will cover it and they will treat it that way. That is huge news, because as you know, in the past, this NGS testing, somatic testing, you were only permitted one test in a lifetime per cancer. And we objected to that and said, no, for some cancers like prostate cancer, we know it morphs. You've got to have more flexibility there. And it looks like we have the flexibility. So you can read in the blog. I put the blog post in the chat window. And also, by the way, talking about the chat window, I also put the registration for PCRI for you in there, and we'll probably blog that out as well, or it'll certainly be in all the reminders that you get over the next week or so. So we're gonna move on to Dennis Correa.
Yeah, I just want to update you and everyone on my annual scans at Mayo Clinic up in Scottsdale. I had that done yesterday, and it was a CT from the pelvic area and the abdomen and the chest. And they put up, I actually did a telebed with Dr. Singh yesterday afternoon from home. and he put up the scans from last time and this time, and there's virtually no activity in any of the tumor cells where they were, or the lymph nodes. So very good news from that standpoint. And so along with that, I had let him know in advance that I was going to talk about neuroendocrine or morphing to neuroendocrine. And so what he had proposed and I was ready to do, because of some gentle prodding by some folks on this call and my own investigations that I have done, I am now going to take a drug holiday, and I will no longer be on Lupron, abiraterone, or prednisone.
Uh-oh.
So I got to wean myself off of the prednisone. That's the only thing.
Dennis, how many shots is that worth on your handicap?
I got to give my golf buddy some fair warning to watch out, because that ball is going to be going 20 yards further every time when I. No, but I've done all the right stuff, everything that I could possibly do, the exercise, the diet, being very precise with my choice on the drugs, and taking them very precisely as specified, and it's worked well for me. All my PSA has been down to less than 0.1 for the last 3 to 3.5 years. And of course, I started out over 4 years ago with a dose of Taxol because I was diagnosed metastatic large volume bone mets up in the spine and both in one femur. And of course, I had after about 6 months to a year, I think I had a progression after the chemo, and then that's when they added the abiraterone, the Zytiga at that time. And that's where I saw the biggest change was with the Zytiga. Really took the PSA down to less than 0.1 is the way they report it. So I just can't tell you how happy I am. This is great.
Great. And kudos, and I want to say kudos to you for being flexible enough to consider it, because I know in the past you've told us you wouldn't, and I think it's great you're doing it. But I would like to get the opinions of 2 people on this call to help you, if in no other way, psychologically with your drug holiday. I'd like Len to talk to you because he's been on a long drug holiday, gone back and forth, and I'd like Peter to talk to you. Len, what are your words of wisdom for Dennis?
Yeah, well, congratulations, Dennis. It's great news. I would just ask you to lower your expectations on the recovery of your T levels. You've been on Zytiga for at least 3 years. Is that right?
Yeah, and I'd be 75 in a few months here. And, unfortunately, I don't really know what my PSA was at when I started. It wasn't something they were doing at that time.
That doesn't matter. Oh, you mean your testosterone? You don't know what the level was?
Right.
Yeah. Well, yeah, because of your age and how long you were on ADT, it could take a while before you start to see any significant movement upwards in your T level. But, it's a psychological boost, so you'll probably feel better just knowing that you're not taking the drugs anymore. A little placebo effect.
Yep. Dennis, have you frozen there? Are you still with us? Can you hear us?
He's frozen.
I think he's frozen. Well, hopefully he can hear us. So let me just if not, he'll listen to it again, I know later. Dennis, I think you're frozen, and I'm hoping your microphone shows it's open, but now your camera's gone. Can you hear us, Dennis? Okay, well, we'll keep going. Peter, give Dennis your words of wisdom, and push comes to shove, we'll make a note that this is at 4:19, so we're about an hour and 20 minutes in, so he can listen to it. Go ahead, Peter.
This is the best news I've heard in a long time, Dennis. I think it's great.
I apologize. I lost my connection, and so I missed most of what Len had to say. It just came back on.
Okay.
In a quick summary, Dennis, I was saying that given your age and how long you're on ADT, you'll have to be very patient as your testosterone levels might be very slow in recovery, but that just the mere fact that you're off of all your meds will give you some kind of a placebo boost, I'm sure, and psychologically you'll feel better.
Yeah, that's what I'm looking for also is, I can do away with so many of those side effects from the ADT. At least I'll have a little more energy. I think even if I don't get the testosterone back, just doing away with so many of the side effects will help.
Hey, Peter.
I agree. This is the best news I've heard in a long time, Dennis. And I think you're going to find this will boost your golf game considerably, if nothing else. It's worth it for that. And in my experience, by going on and off several times over the years, is that it's nothing to be afraid of. You can always go back on. I mean, this is not going to run away and be a cause of doom and gloom and out of control. You just monitor things carefully, do a monthly blood test or whatever, keep an eye on things, and if you see a creep, then talk to your doc, and you can always go back on something. So I'm thinking, I think every day that maybe I should go off again, and it's one of the conversations ever to have with my doc. So congratulations. I think this is great.
Yeah, thanks, Peter.
Okay, anyone else want to say anything to Dennis before we move on? Okay, so Russ, are you there? Because your microphone is off. Now it's on. And Larry Fish, do you have your stopwatch out? Well, we don't see that. So if I were you, Russ, get talking, because it doesn't look like he started his timing yet, because I don't think he's there. All right, you're up.
It's going to be quick. It's just like each day post radiation and weaning off of ADT, I'm getting stronger. I'm feeling better. And so far, everything's good except for diagnosis with the kidney tumor that we're going to keep an eye on. So that's all. That's it. Things are better.
Good. And let's call it a kidney cyst and not a kidney tumor, please, until we know better, okay?
Yeah, well, 70%. So, but okay.
Until we know better, for the purpose of this call, we request you refer to it as a lesion or a cyst. Okay?
Yes, sir.
Thank you.
Yes, sir. I'm done.
Okay, well, we're good. We're good. You're feeling better, and so maybe you'll be ready to play golf with Dennis Correa if we can ever get the two of you together. Oh, Larry Fish.
I cheat though.
Larry, oh, you cheat. Larry Fish arrived. Now he arrived, but it's too late because Russ is finished.
Too late, it was so weird. I hear myself. I'm getting feedback now. By the way, I'm here twice, which I don't understand.
Hey, you think that's a problem for you? What about for us?
You get the pleasure of double the pleasure.
Okay. Herb, you're up.
But that was a minute, and I heard you the whole time. What's wrong?
So to bring some of you up to date. So yeah. I started off this journey a year ago when my PSA started to go up after a routine exam from 1, and then it got to 3.4, and my GP said, you should look at it. So we went off to a a biopsy. At that point, the PSA was something like 8 or 9, and that was in last August. Biopsy showed every tumor everywhere. The pathology at NIH said it was a Gleason 10. The pathology at Hopkins said it was a 9, which to me doesn't mean not a big difference. So they started me off on chemo, and I had 3 rounds of Taxol, and after that, by that time, the tumor, the PSA at the height was something like 28, and then after 3 rounds of chemo, it was 8, but they decided that the side effects were too significant. So at that point, switched me over to abiraterone, where I am now with a PSA stable around 2. And that's been stable for, a few months, but it's gone steadily down for the last 9. So from the beginning, I've read the clinical trials that said there was some benefit to radiating the prostate. And so today I met with a radiation oncologist and had a very long discussion about doing it. And her take on the story is, number one, the trials of radiating the prostate in the presence of metastatic disease suggest a dose of radiation that is not as high as that used for curative goals. So she would use like 70 to 80 gray over 4 weeks, 20 sessions aimed at the prostate. She did not want to do the whole bit, although the scan showed extraseminal involvement. And so the other thing that she was concerned with was that, that I didn't have too many side effects, number one, from this, because it does have negative consequences. And number two, that it wouldn't prevent other future treatments. So after an hour conversation with her, she said, based on the clinical literature, I'm borderline. It could go either way. There's not a clear evidence-based decision as to whether to do the radiation or not. So it's sort of, what do we do? And then after consulting with my medical oncologist, I got the email today that said they're on board. They have no objection to my doing the radiation. However, they don't have any sense of whether it will really improve anything. So the question I have for you, because I don't know, for those of you who have been through this, what's the cost benefit analysis of doing this, and if, and whether I should go through with it. So I don't have a sense of other people's experience. And my PSA is 2, and that's not, yes, it's a lot lower than it was, but it's a lot higher than I hear from some of you on abiraterone. So I'm still concerned that there's a significant tumor burden. And lots of mets. I mean, mostly bone mets, no lymph nodes.
Let's try and get some feedback from people that have treated the primary after they've been diagnosed metastatic. And I see Ken Anderson, I see Dennis McGuire, Jerry Pelfrey. Those are I may have missed, if I did, forgive me, but I think those are the 3 that shout out at me. And by the way, just to repeat what I said before, I don't understand why these doctors are reticent to treat the whole pelvic girdle when they go in and treat the gland for somebody who's metastatic. And we see that right now, anecdotally, with Dennis. So let me start with somebody we haven't heard from today who got diagnosed with a PSA of over 2,000. Jerry Pelfrey. Jerry, do you want to just offer your opinion on treating the primary?
Well, I did it a little differently, I guess, but I used proton rather than photon to ablate my prostate. My reasoning for that is because proton therapy only goes to the site that you want to radiate, whereas X-ray goes through what you're radiating and continues through the rest of your body. And that causes some of those incontinence and other side effects. So it was simple, it was easy. It took me 4 weeks to do at Mayo under Dr. Shields, the radiology oncologist. So he treated it. That's about all I can say. I really don't know if he treated the full pelvic girdle. I talked about that, but I don't remember him saying anything about that.
And the results?
The results are good. I mean, if you want me to tell you now, and I won't, my labs, my PSA is down to 0.01. My testosterone is 0.025.
So Jerry, what was your PSA before the radiation?
Before the radiation, it was 2 something. I don't quite remember what it was. It was over 2.
But we should
now
add,
I had that.
we should add,
My proton.
Jerry, hold on a second, Jerry. We should add that you were diagnosed with a PSA of over 2,000 and it got brought down by your chemo, correct? Before the radiation.
Actually, my ADT brought it down.
Okay.
I was 3,100. I was 3,195 on February of last year when I was diagnosed at Mayo for February 6th. He put me on Firmagon for 1 month, and then I started Zytiga with prednisone and on Lupron. My next, I believe it brought it down from there to somewhere around 90, and then it went to 56, and then it went to 26, and it kept coming down, but I don't remember exactly my PSA right before I had the proton. So I'm doing great. I had no side effects from that at all. And my next question that I had was, I'm reading about proton therapy, but nobody said really what it's specifically for, but it sounds like it's one of the new avenues rather than just photon. I'd like to know if anyone knows about proton therapy. But
Yes, I mean, I've certainly been reading about proton therapy, and it's certainly much more accurate. And the only trials, though, indicate that there's no difference in outcomes.
Right. So let's just hold off on the photon and proton discussion. I was going to go to Ken Anderson next, but he just got up and walked away. He'll be back momentarily. Dennis, what about your decision to treat the primary and the before and after?
Yeah, so I treated my primary 4.5 years after initial diagnosis and several treatments. And it really came about when I changed hospitals and doctors. They just had a different outlook on treating the primary. I had very, very few side effects. Some fatigue the day of and the day after the sessions, but it was only, I think, 5 sessions short. It's probably too early to say if it was successful, but the latest scan shows that the prostate is pretty well ablated to nothing.
And that was
After,
Do you know the
5
dose that
months.
you got? Do you know
I
the
don't
dose
remember,
you got?
no. I don't remember the dosage.
The dosage was SBRT, Herb. So that
Well, but
might.
it can vary.
Oh,
That,
I thought you meant like what the gray level.
yes.
Right.
I don't know.
Gary, do you remember what your gray level was?
Yes, it was 50.
Okay, with proton. With proton.
With proton.
Right. And let's get Ken Anderson into this conversation because he went through the same thing. And Ken went through, I believe, with photon and IMRT. Ken, what's your thoughts? And
well, I pulled up my charts from 2017 when I did IMRT, and I did 84 grays. I did the prostate bed and the prostate. Based on Paul's recommendation, we originally considered doing a radical prostatectomy in a clinical trial, but the clinical trial had two arms, and one was you didn't get it and one you did. So I said, if there was any benefit whatsoever, at least possible benefit, I guess, then I didn't want to go down the 50-50 chance. So the option was, after we decided that it was something that I wanted to do, and I must admit it followed 6 rounds of docetaxel, real close. So I can tell you the dates. In April of 2017, I started docetaxel and I finished it in July. And then at the same time, the next month, August, I started the 84 grays. At that time, my PSA was 1.1. So there might be a little like carryover of docetaxel, but the next month my PSA went to 0.6. And then gradually through the next, honestly, 3 months, it was all the way through Thanksgiving, my PSA dropped to 0.4. So I think taking the prostate out of the picture was a big plus. At the moment, of course, not so much, but I mean, I can see, at least on my chart, and I'd be happy to send it to you. It shows, March of 2017, my PSA was 726. And then it dropped to 52 the next month after doing 2 cycles of docetaxel plus doing ADT, which at that time I was only doing Lupron. So the Lupron, ADT, the docetaxel plus taking the prostate gland out of the picture took me down to 0.4. So I have to say the combination was effective. Do you have any questions, Herb?
Well, I mean, I guess it all the rate again. How much radiation did you get? Did you say?
84 grays.
84 grays. So it's really a curative dose. That's generally aimed at being the ablative dose.
So
yeah, they took out the gland and the bed.
The other thing that I asked her, did she think that I should just talk to somebody else as well? And of course she said yes. So that's what I'm contemplating now, is whether again I should get another opinion before going through with it.
Okay, so let me give you one other more input on this. I forgot from my fratello Lenciera, who we finally convinced to treat the primary. It took a long time, but we did finally convince him. I always forget, but yes, he was metastatic and he didn't treat the primary to begin with. Len?
Yeah, that's right. And the reason I was slow to take on the advice of Rick and Dominic, who's no longer with us, is that my MSK oncologist said, no, radiation would be a disaster for you. Well, he was just plain wrong. So all he did was, I was a Gleason 9 and I had seminal vesicle involvement and 3 lymph nodes, pelvic lymph nodes, similar to you. Although I didn't have bone mets at that time, at least not that were detected. Of course, they were more primitive scans. So it was, let's see, I was diagnosed in May of 2014, and it wasn't until July of 2016, more than 2 years later, of just being on and off with ADT, that I had, Rick stopped pounding me over the heads because I agreed to do the radiation. Now I had 86 gray, which nobody in the country does except MSK. It's very high. But I had the prostate and the pelvic girdle because I had pelvic lymph nodes. But I believe, Herb, you said you don't have pelvic lymph nodes.
I do not have pelvic lymph nodes. I have extra seminal involvement.
Yeah. So, with a Gleason 10, I don't know. What did you have a really sensitive scan, a PSMA?
Yes, of course.
Yeah, you did. And even that didn't bring up any pelvic lymph nodes.
It didn't bring up anything that they didn't see before.
So maybe you don't need to radiate the entire pelvic girdle. I don't know. I definitely get another opinion. I was kind of stalling out at about, before the radiation, at 0.45 PSA. I was originally 49. And I was only inching down very little. So after the radiation, it went down to 0.1. Long story short, after that, I was on 28 months of drug holiday before my PSA started rising. So I think it was very effective. I think it held the disease at bay for quite a while.
And Herb, we got one more for you, but this one's surgery. Carl, put in your 2 cents as well for treating the primary, because you did treat there was a big decision to treat the primary. You were diagnosed metastatic.
Right, and that's why I went into a clinical trial at my at Rutgers Cancer Institute, which Herb is familiar with, and the decision was made by me because of the fact, well, it's prostate cancer, so let's get rid of the prostate. So if I hadn't had the surgery, because I had not been told previously that I had seminal vesicle involvement, and I had 2 lymph nodes positive, so I don't know, how things would have progressed or not, and how they would have found it after the fact. So, and then the rest is history, so to speak, because I did have the genetic testing, and the genetic testing for me was really the key of my treatment going forward.
Right. Thanks, Scott. So, Herb, we've covered 5 guys for you, and there could be a couple.
I think
moving. What do you think?
I think now the difference is, do I go and talk to somebody who does proton therapy, or be happy to stay at NIH with SBRT?
Okay, Peter or Les, who would like to? Les, we haven't heard from you today. You finished up doing proton at Mayo, correct?
Yes, I did. However, I don't know if I am good at giving an evaluation or not.
We try.
Well, I don't know how to compare it to anything. I can't compare it because I didn't have both ways.
But did any of you guys have side effects from these things, like bowel problems or other issues? I mean, that's where they're worried.
I had problems for 18 months, Herb, but then I did develop some radiation proctitis. But again, I had full pelvic girdle. If you don't have that, your side effects are going to be less than what I had. You probably won't get the proctitis. How your urinary function is good right now?
It's okay. It's not fabulous, but it's okay.
Yeah.
Okay. Peter, well, you had your, you weren't metastatic at diagnosis, but you had your prostate removed, but then you did subsequently you did proton beam. You decided to do proton beam. Any words of wisdom for Herb?
I don't think my situation is applicable. Mine's reverse of yours. I went right from 80 2 surgery, prostatectomy, and 11 months later, 39 days of photon radiation, IMRT. But I had seminal vesicle invasion right from the get-go. I mean, I knew the cat was out of the bag. I knew it was systemic. So it's just, so I'm doing the reverse. I'm kind of chasing after it. I went after the source right from the beginning because I had urinary retention right from the beginning. So I had to do something. It was too miserable not being able to take. So I can't really give you much advice other than the fact that I'm still going 6 years later, even after chemo now, and the side effects are not, it's all manageable. I mean, this disease is manageable, whatever you do.
Yeah, and Herb, I had 50 odd grays of brachytherapy and about another 45 grays or 43 grays of IMRT. And again, It was different. And yes, I have issues that it's left me with, but I'm very happy managing those issues versus the alternative. Of course, I was T3, I wasn't metastatic. I think that there is some risk. There are some docs, if they're just going to radiate the gland and they're doing it with either SBRT or, the options are SBRT, IMRT, or proton. So Dennis had SBRT, Len had IMRT. I don't know if anybody here had proton for just solely for the gland or not. Les,
I did, Jerry.
Oh, that's right. You of course had. So you had proton for the gland. Thank you, Jerry. Thank you. Yes.
Not only for the gland and the bed.
And the bed.
And no other side effects than what I already had, which was with Lupron and Zytiga, which we all know.
Right.
Which is what I have, just the same as you.
I mean, I can only tell
thank you all.
If it were me, I would be treating the primary today, knowing what we know. 10 years ago, nobody did it. And if they did, it was either Mayo or MSKCC occasionally, and they were only doing it with surgery. But the last 3 years, I mean, these docs say, well, the trials aren't out there. One of the reasons is because it's really only in the last 3 or 4 years that we've seen this move towards treating a primary, either with surgery or with radiation. So yeah, that's why the results aren't there. I would encourage you to get a second opinion. There are some good radoncs at Hopkins. That would be a good alternative, or at Duke, that would be a good alternative for you.
No, Hopkins would be where I'd go. I mean, I've already got connections, and it's very convenient.
Okay, well, let us know who they suggest, and maybe we can help you with that decision.
Great. I'll be in touch soon. Thank you all.
Okay. Thanks. We'll keep moving. We've given that one a fair amount. We're going to do a very quick stop by Peter Monaco. This is just a good health visit because Peter had some significant surgery last week unrelated to his prostate. And we want to know, are you doing the CanCan yet, Peter?
I'm a long way from that, Rick, but I'm feeling okay. I'm
Good.
happy to have this thing over with.
Good. Just tell the guys what they did.
Well, I needed hip revision surgery. I had my hip replaced 13 years ago, and the implant went bad. We thought it was metallosis, which is a shedding of metal particles into the bloodstream and the surrounding tissue. So my surgeon was going to just go in and take the metallic ball head of the femur part and replace it with a ceramic, and then also change the cup that's inserted on your pelvis. and that would have been it. But when he went in, he found that actually what was causing my pain was that there was bone overgrowth on the pelvis side. Bone had actually grown over the cup that was embedded and created an impingement on the ball, which was something I thought I felt. I could swear I felt some kind of strange movement when I took a stride. I'd keep my finger on my pelvic bone there, and I'd say I could feel I felt the motion of it moving outward. And he said it was probably that. He said because it was pushing the ball away, not in a symmetrical motion anymore. So it didn't change what he had to do when he saw that. He just explained what was going on. And he went ahead and did what he had to do, which was to change the parts, squirted in a little WD-40, some grease gun, whatever. And, one thing led to another, and I was out of the hospital in just one night.
Fantastic.
And that was a week ago. I was petrified about having to go into surgery in the midst of a pandemic, but the place I went, they haven't had any cases of COVID there in months. And it's a great place, Morristown Medical Center in New Jersey. And it was a good experience as far as surgery goes. It was a week ago today, as a matter of fact. And I'm doing much better. I'm hobbling around on a cane, doing my physical therapy, and expect to be back to normal in about 3 months overall.
Right.
Yeah.
By the time Dennis Correa has recovered some of his golf game, it should be just about right for when you start swinging that club again. So maybe the two of you have to figure out where to meet.
That works for me. That's the whole tragedy of this thing was the whole tragedy of this thing was. Are you near there? Are you near there?
No, Dennis is in southern Arizona.
Oh, I'd love to go out there to play.
Well, I'm sure Dennis will take care of you. Yeah. I know Dennis. He's ready to entertain you. Herb, what were you thinking?
If he's in Morristown, he can go to the Trump Resort.
Oh,
okay. Yeah, that's right. It's right by there. That's right. Well, I mean, the big tragedy of my thing was that I missed out on the golf season. I was just so annoyed about that. But what are you going to do? You're
going to come to Arizona in the winter and play a couple of rounds with Dennis is what you're going to do.
That's the problem down here. The golf season is 12 months out of the year. I'm coming here for a good time to play, to have something like that done.
All right, let's keep going. I promised Carl I would reserve time for him. We've also got to get to Madav and Jeremy and Jim. We'll do the best we can to get around everybody before the caregivers rush in.
Okay, I'll talk fast, I guess. There was a lot of discussion a little while ago about PSMA scans, and that's something I'm looking into. As Lynn had suggested to me, I spoke to Yolanda down at NIH. I actually applied for their clinical trial, and she did not hold up any hope for me to get in. That it's virtually at a standstill at this point. And although I'll be on the waiting list, there are other people, the internal candidates, whatever that means, would have more better preference than I. So she said, you should pursue other options. So I went on to clinicaltrials.gov. I live in New Jersey. I went to see within a 100-mile radius of where I live what popped up. And there were a total of 16 possibilities. I narrowed that down and found, to my surprise, that Sloan Kettering has although it's not specifically a trial, they call it an observational study, and it's for diagnostic purposes. So I said, oh boy, I never heard of that before. So they have a PSMA scanner in Manhattan, and I spoke to them about it. It's not really a clinical trial, but it makes available the PSMA scanner for people. And they said it's unlikely it will be covered by insurance. And that if I want to have it done, and Rick, you had already mentioned the price, I think was at UCSF or some other location. Well, they're charging $7,500 for their scan. And so it's that as a possibility versus me going possibly overseas to Germany or Australia to have it done there, which is unlikely for me to do. There are also 2 other locations relatively close by. There's Weill Cornell, and there is also Columbia Presbyterian, which I mentioned at the last meeting here with Dr. Mark Stein, which is with CAR T cells. And both of these other trials, in fact, the majority of these trials are phase 1. So phase 1 is telling me that they're trying to determine the best non-toxic version of the treatment. And so I'm really concerned about going into a phase 1 trial. So it appears my main option at this point is spending the $7,500 and having it done at Sloan Kettering. They said they do have a clinical trial, but it's only open, no surprise, to their existing patient base. No outsiders. And
okay, Carl, let me interrupt you. I mean, you can go to UCLA for 2,750. Right, and then you could just, spend the other 3,000 on flying first class. But I mean, seriously, and Len's put something in the chat window about the trial at Carbone. There is a trial going on in Virginia Beach, Norfolk, that Rich Jackson has participated in yesterday or earlier this week. So, there are other options, and you might want to just keep looking at those other options before you dig into your pocket for the $7,500 for Memorial Sloan Kettering.
Yeah, I guess when I did the search, I did it within 100 miles of where I live. So it wouldn't have picked up Virginia or UCLA or some other, Norfolk.
I heard UCLA was charging $2,500.
Okay, 2,500. Oh, okay. The other 250 was our commission, Len, for AnCan. Now you blew it. Now, somebody. I kept hearing 2,750, but maybe it's 2,500. Peter, wasn't you kept telling me it was 2,750?
That's what I heard. Yeah, UCLA. At least it was recently. And Rick
Aldridge
would know for sure. He had it done recently. And it's only a 2-3 hour procedure, and there's no side effects. I mean, I fly 2,500 miles to do it. I mean, you can ostensibly do it in one day. If worst case scenario, you get a hotel by the airport overnight. Big deal. And it still saves you thousands.
Okay.
Anyway, guys, we spend a lot of time talking about these PSMA trials. I'm going to put out a request right now. I just don't have time to do it, but if there's anybody on this call who would be willing to do some thorough research and come up with some options, because it seems like every call we talk about these PSMA trials, and rightly so. But we really need somebody to do some real digging here and come up with 5 to 10. Peter, would you be willing to do that?
Yes.
Thank you, Peter. Thank you, Peter, because that will be a huge service. We'll publish it on the blog. We'll talk about it here, and it will be a service to a lot of guys if you can come up with some realistic options around the country for PSMA scans. We have Don Line has just joined us. Don, this is the end of the high-risk recurrent active surveillance call, and we have somebody on the telephone. Who is it that's on the telephone? Were you joining us for the Caregivers call or for this call? Someone on the telephone who hasn't identified, or somebody who's identified and called in as well to fool us? We don't know. Well, whoever you are, caller, stay on, hang in. We're moving like a train right now to try and get through everybody.
Just very quickly, just to remind you, Rick, as you have referred me to UCSF, Pamela Munster, I am having my telemedicine appointment with her on this Thursday.
Great. Well, tell her we said hi. You know, I don't know what UCSF is doing, but if we find anything, we'll let you know. I don't know where they stand, and be sure to follow up in the chat window with the links that the guys have put in today on a couple of trials. One in Madison, Wisconsin, one in Virginia, in Norfolk, Virginia. Madav. I'm sorry for you guys who came on a little bit later. Oh, let me welcome Renata. Renata, we're at the tail end of our moved prostate cancer call. We'll be moving right from this into our caregivers call. So just bear with us for a couple of minutes. Madav, tell us what's on your mind. Can we, or if you can, come visit with us on Monday.
I'll go quickly. I'll give you 2 minutes. I just wanted to thank everybody as well for the second opinion doctors' names you gave me. Alicia Morgans was one of the best doctors I've spoken to. So thank you so much. I'm on a situation, obviously it's a recurrence for me. I was, operated and radiated last year. PSA was fine until April. It went up from 0.2 to like 1 in like 2 months. So the damn thing was racing. So we went into the PSMA. So I did exactly the same Blue Earth trial, as well as, the PET scan to face off with it. Both of them actually came back negative. So even though the PSA had gone up substantially and they were but they were expecting to see, some tumor, we couldn't find anything that was material. So what I've done now is I've gone on to ADT again. I took Firmagon for the first time, which was pretty radical. It really affected me for the first week, but I'm much better now. And on Zytiga as well and prednisone. I'll be moving on to Lupron in a month and continue the Zytiga. The question I have for you really is they've suggested that I stay on the ADT for about 9 months. I think it should be longer. This group has counseled me earlier that I should be longer. So we're talking about that, but so that's the status I'm at. I'm feeling good and in the treatment, but just as concerned about the length of the ADT now for me.
Okay, so again, Susan, bear with us, and Wendy, Susan, bear with us. We're just tying up the old call. Susan, I know you're very happy to listen to this, to contribute on this. You have plenty of experience. Madav, did you say that nothing showed on the PSMA? Did I catch that right?
Nothing material.
Okay, so here's what I would like to suggest. I mean, how long you stay on ADT is a discussion I really would like you to have with some of the guys. And we don't have time to do it right now, I'm afraid.
I'll come.
Because I think you might have missed the beginning, but because of the quirk in the calendar, we had to move our second Tuesday meeting back to the first Tuesday. Otherwise, we would have had meetings on successive days. And on the first Tuesday, we have a 5 o'clock meeting for the caregivers. So that's why you're seeing some action right now with the caregiver moderators coming in. But I don't want to dismiss this conversation. I don't think anybody on this call wants to dismiss the conversation. How long you spend on ADT, I personally think is very important, because anecdotally and purely anecdotally, where I've seen men to too little time on the ADT initially, they've had issues and the disease has come back too quickly. So if you can join us on Monday at 5 o'clock, 8 o'clock Houston time. You're Houston's on Eastern time, isn't it?
It's Central, but don't worry, Rick. I don't want to waste any more time. So I'm absolutely fine coming next week, so you can keep moving.
Please come back in. And my apologies to Jeremy today and to Jim B. We just had a lot. We had a lot of guys, a lot of action, but we will do our best. And if it's anything urgent, just email me or Len, and we'll get back to you and we'll respond to you. So if anybody would like to stay for the caregivers call, if any of you happen to be providing any care for cancer patients, you are more than welcome to stay. We would love to have you. If not, we will see you next Monday. Okay.
See you guys.
Bye, everybody.
Bye-bye.
Bye. Great job, Dennis.
Have a good week. Take care, guys.
Bye. Bye. Bye.
Night, everybody.
Good night. Good night. Good night.